كمان الدكتوره دعاء الفضالي. ازيك يا دعاء، اخبارك ايه؟
ازي حضرتك دكتور ابراهيم؟
هتكلمنا على الكومن ميستيكس في الجلوس بريسكريبشن في تشيلدرن، ودي حاجه مهمه جدا جدا الحقيقه.
السلام عليكم، شكرا جزيلا للدعوه الكريمه. وان شاء الله هي مش ميستيكس، هي اكشولي بيتفولز كلنا بنتعلم منها في عياده البيدياتريك اوفثالمولوجي. أول حاجة I'm going to start with the natural history of the refractive error. We all know that from the age of 0 till the age of 1 year, all the children have high hypermetropia ranging from +3 to +6 diopters. And up to the age of 12 months, immetropization happens very fast. Thereafter, after the age of 1 to 2 years, immetropization becomes very slow. And here are some developmental facts about the immetropization, which is the process by which the refraction of the anterior segment of the eye balance the axial length, where immetropia happens. And the rate of this immetropization varies between the children. The children with the strabismus and the high refractive error tend to immetropize at a lesser degree compared to the normal children. And before prescribing spectacles, we have to answer these questions. Is this error within the normal range? And is this error very likely to immetropize? Does it disrupt the normal binocular visual development for these children to give us a justification for glasses prescription? And these are really difficult questions to answer. Hence, most of the guidelines are based solely on the clinical experience rather than randomized clinical trials. But what we all know is cycloplegia is an absolute mandate for all children in all pediatric ophthalmology clinics. Up to the age of 12 years, you have to cycloplege every single child. Beyond the age of 12 years, you can get away without cycloplegia by doing a subjective trial or subjective refraction. And that's the table for the preferred practice pattern from the American Academy of Ophthalmology. We might not agree with all these numbers. Some of us have lower threshold for glasses prescription compared to these tables, but that's the general guideline. And these values were generated by consensus and are based solely on the professional experience rather than a rigorous published data. So I'm going to start by mentioning 6 cases we can learn from in a pediatric ophthalmology clinic. Case number 1, that's a 5-year-old with a right esotropia, and the vision in the right eye by the crowded case book 0.2 and the left eye is 1. So the cycloplegic refraction is +5.5 in the right eye and a +4 in the left eye. We all agree that esotropia with hypermetropia, we will prescribe glasses. But the common mistake here is to start by patching without a period of refractive adaptation. It is advised to have a trial of 2 to 4 months of refractive adaptation according to the PEDIC trial. And this glasses prescription can be in itself very sufficient for amblyopia correction before commencing the patching. And especially in a community like in the Upper Egypt, the glasses prescription sometimes can be a stigmata in itself. So start it step by step, glasses prescription first and then the amblyopia treatment if the vision is not improved. And here's the child after 2 months of only glasses prescription and the vision in the right eye 0.9 and the left eye is 1. We know that the fully accommodative esotropia, you should correct the full plus of the patient. However, it is advised to leave the patient small or slightly esophoric to compensate for stimulation of fusional divergence to get this child fast immetropization level. Case number 2, that's a similar child, but after glasses correction, the patient is partially accommodative. Still, there is residual esotropia at near and distance measuring about 30 prism diopters, and the vision is equal in both eyes. Most of us will rush into partially accommodative esotropia, rush into surgery, and that's one of the common mistakes. Sometimes, if the patient came back after 2 months of glasses prescription, whether it is you who prescribed the glasses or another doctor, just re-refract. The patient in the initial visit might not be completely cyclopleged. In a basic clinic, sometimes you didn't wait for the complete cycloplegia, so re-refract to make sure that it is not under-corrected fully accommodative esotropia. And when it comes to the surgery, don't work on the standard formula. You will have a higher rate of undercorrection. Instead, we use the augmented formula. It's mixed between the highest angle and the nearest angle. Sometimes we use the prism adaptation. Case number 3, that's an 8-year-old with a vision equal in both eyes, 1.0, and esophoria in the distance, and in the near, it's a 25 prism diopter. And the cycloplegic refraction is 0.5. So this patient is not accommodative, and the vision in the near and distance is equal, and the angle of deviation is more in the near than the distance. The common mistake here is ignoring measuring the distant angle of a squint and relying solely on the near angle for correction of a squint. If you corrected this patient based on the near measurements, you might have a consecutive exotropia in the distance. And this patient turned out to have high ACE ratio, accommodative convergence over accommodation ratio. And the easiest way to measure this, measure the largest angle and the smallest angle, divide them, subtract them first, and then divide them by the lens used, which is conventionally a +3 lens. And the basic treatment for this patient is a bifocal glasses, and that's a convergence excess esotropia. I would advise most of you is to read review article about the convergence excess esotropia. And the initial treatment is a bifocal correction with a more than 50% success rate. So the take-home message here, measure the near angle and the distant angle. Case number 4, that's a 1-year-old with bilateral aphakia and a refraction of a +17 in both eyes. Should we prescribe the +17? In patients with aphakia and pseudophakia, these patients no longer have accommodation, and most of their activity is just the near world. هم علاقتهم كلها بالحياة بزازة, even in the breastfeeding, لعب كلها in the near world. And since they don't have accommodation, we should overcorrect these children with a +2.5 or a +3 more than their actual cycloplegic refraction. That's according to the preschool age. And when they come to the preschool age, or the nursery age, when they start doing homework, start giving these either in a separate readers or in bifocal children. So the common mistake here is just giving the +17. But when it comes to the actual real world activity, what they all need is a +20 or a +19.5. Case number 5, that's an 11-year-old with an intermittent exotropia with a fair to good control, and the vision is excellent in both eyes, and that's the cycloplegic refraction. +1 in the right eye with a -3 astigmatism, and in the left eye +2.5 with a -3.5 astigmatism. We will all agree that this child we will start by prescribing glasses. And the common mistake is to just take out all the plus from both eyes. What we should do is symmetrically reduct and respect the anisometropia, which was there, the +1.5 difference between the right eye and the left eye. So what we should prescribe is taking all the plus in the right eye and do a symmetrical reduction of this plus in the left eye, and that's the glasses. So the common mistake, we all undercorrect, but we should respect the initial anisometropia and make a symmetrical undercorrection between the right and the left eye. This is my last case, a 5.5-year-old with a vision in the right eye 0.1, densely amblyopic, and good vision in the left eye with a -9. Should we prescribe the glasses? Start by measuring the axial length to make sure that it is an axial myopia, not a refractive myopia. When the axial length is higher in the right eye, this is an axial myopia. We all know from the Knapp's rule that the relative spectacle magnification when we prescribe the glasses will be 1. So this child will no longer have an isoconia. But should we wait for the amblyopia management as the first child? I wouldn't advise waiting longer for these cases. This child spent 5-6 years with dense amblyopia. Very unlikely the refractive correction in itself will help the amblyopia. So I would advise starting the patching or at least bring him at a sooner visit. Thank you very much for listening.